Good evening, everybody. This is Brother Wolf, and tonight we have for HS 375, Group 6, on hospice and palliative care organizations. And I am going to turn the time over to the group, and I believe Janet's starting first, so whenever you're ready, feel free to start.
Hello. We're presenting tonight, and we hope that you can join us. We're talking about hospice and palliative care. Next slide, please. Caitlin, can you go to the next slide?
I did. Did it not work?
I don't see it.
Yeah, it's still on the first one. If you click over on the left, click on the slide 2. If you like, highlight the box. Yeah, there you go. That should double click it. Yeah. Did that work for everybody? Okay.
It did. Thank you, Caitlin.
Yeah.
What is hospice? Hospice is a specialized type of care for those facing a life-limiting illness, their families, and their caregivers. Hospice care addresses the patient's physical, emotional, social, and spiritual needs. Hospice care also helps the patient's family caregivers. Next slide, please. Palliative care is a multidisciplinary approach to specialized medical care for people with serious illnesses. It focuses on providing patients with relief from the symptoms, pain, physical stress, and mental stress of a serious illness, whatever the diagnosis. Next slide, please. The difference between hospice and palliative care. Hospice care and palliative care are very similar when it comes to the most important issue for dying people. Care. Most people have heard of hospice care and have a general idea of what services hospice provides. What they don't know, or what may become confusing, is that hospice provides palliative care, and that palliative care is both a method of administering comfort care and increasingly an administrative system of palliative care offered most prevalently by hospitals as an adjunct or supplement to some of the more traditional care options. Both hospice and palliative care protocols call for patients to receive a combined approach where medication, day-to-day care, equipment, bereavement counseling, and symptom treatment are administered through a single program. When palliative care programs and hospice care programs differ greatly is in the care location, timing, payment, and eligibility for services. Next slide, please. Hospice programs far outnumber palliative care programs. Generally, once enrolled through a referral from the primary care physician. A patient's hospice care program, which is overseen by a team of hospice professionals, is administered in the home. Hospice often relies upon the family caregiver as well as a visiting hospice nurse. While hospice can provide round-the-clock care in a nursing home, a specialty-equipped hospice facility, or on occasion in a hospital, this is not the norm. Palliative care teams are made up of doctors, nurses, and other professional medical caregivers, often at the facility where a patient will first receive treatment. These individuals will administer or oversee most of the ongoing comfort care patients receive. While palliative care can be administered in the home, it is most common to receive palliative care in an institution such as a hospital, extended care facility, or nursing home that is associated with a palliative care team. Next, please. Timing. In hospice, you must generally be considered to be terminal or within 6 months of death to be eligible for most hospice programs or to receive hospice benefits from your insurance. In palliative care, there are no time restrictions. Palliative care can be received by patients at any time, at any stage of illness, whether it be terminal or not. Next slide. Payment of hospice. Before considering hospice, it is important to check on policy limits for payment. While hospice can be considered an all-inclusive treatment in terms of payment, hospice programs cover almost all expenses. Insurance coverage for hospice can vary. Some hospice programs offer subsidized care for the economically disadvantaged or for patients not covered under their own insurance. Many hospice programs are covered under Medicare. For palliative care, since this service will generally be administered through your hospital or regular medical provider, it is likely that it is covered by your regular medical insurance. It is important to note, however, that each item will be billed separately, just as they are with regular hospital and doctor visits. If you receive outpatient palliative care, prescriptions will be billed separately and are only covered as provided by your regular insurance. Inpatient care, however, often does cover prescription charges. For more details, check with your insurance company, doctor, or hospital administration. Next slide, please. The treatment of hospice. Most programs concentrate on comfort rather than aggressive disease abatement. By electing to forego extensive life-prolonging treatment, hospice patients can concentrate on getting the most out of the time they have left, without some of the negative side effects that life-prolonging treatments can have. Most hospice patients will achieve a level of comfort that allows them to concentrate on the emotional and practical issues of dying. But in palliative care, since there are no time limits on when you can receive palliative care, it acts to fill the gap for patients who want and need comfort at any stage of any disease, whether terminal or chronic. In a palliative care program, there is no expectation that life-prolonging therapies will be avoided. It is important to note, however, that there will be exceptions to the general precepts outlined. There are some hospice programs that will provide life-prolonging treatments, and there are some palliative care programs that concentrate mostly on the end-of-life care. Consult your physician or care administrator for the best service for you. Next slide, please.
Okay, so the history of hospice care. Hospice comes from the linguistic root hospitality. The term hospice goes clear back to the medieval times, and during that time it was referred to as a place of shelter and rest for those who were traveling far distances. It wasn't applied to specialized care for dying patients until the mid-1800s by Mrs. Jeanne Gardner. Hospice wasn't even really that well known until a physician named Ramay Cecily Saunders created St. Christopher's Hospice in London, England in 1905. And then in 1973, the first hospice was opened in the United States. Then Medicare added hospice benefits in 1983. Now there are about 4,700 hospice providers in all 50 states, the District of Columbia, Puerto Rico, Guam, and the U.S. Virgin Islands. And then according to a study 2009 data, there was 550,000 people that were volunteering in hospice care. The professional and advocacy organization representing the hospice care is the National Hospice and Palliative Care Organization, or NHPCO, which was founded in 1978 as the National Hospice Organization. It didn't include palliative care until February of 2000. NHPCO's mission is to lead and mobilize social change for improved care at the end of life. It is the biggest nonprofit membership organization representing palliative and hospice care programs in the United States, and they have a goal to improve the end-of-life care that people receive and give and they want to give the best that humankind can offer. Whose is this?
It's me. It's actually Ian, and this is Brian, and I am presenting on behalf of him. So we're on to regulation and reimbursement. There are 4 levels covered: routine home care, continuous home care, inpatient respite care, and general inpatient care. The national hospice reimbursement rates for these levels of care change every year. The rate changes are due to annual Medicare changes and are usually a little higher due to the offsets attributable to Medicare coinsurance amounts. Next slide. This table shows the 2016 payment rates, and it also shows what the difference is between continuous home care, inpatient respite, and general inpatient care. And so that's just good information to have. So next slide, please. Eligibility. A hospice provider must obtain a physician certification that an individual is terminally ill, and hospice services must be reasonable and necessary for the palliative or management of the terminal illness and related conditions. A hospice plan of care must be established before services are provided. Individuals must elect the hospice benefit by filing an elective statement with a particular hospice. They must acknowledge that they understand that other Medicaid services for the cure or treatment of the terminal condition are waived. Individuals may, however, revoke the election of hospice at any time and resume the receipt of Medicaid-covered benefits waived when hospice was elected. And I'll just add that I work in a nursing home, and they come in and do interviews with the people, and so they make sure that people really understand what they're doing before they sign up for hospice. And beginning March 23, 2010, with the enactment of the Affordable Care Act, Medicaid and CHIP eligible individuals under age 21 who elect the hospice benefit no longer have to waive services for the cure of treatment of terminal conditions and can receive both curative care and hospice care for a terminal condition. Next slide. This is my slides. The typical organizational structure of a hospice organization. As you can see, there's usually a board of directors that has a CEO, and there's also executive committees which are over various departments. And because there's so many different parts of hospice care, the home care, hospice care, in the long-term care and inpatient care, there's usually somebody overseeing all of those things. And then underneath all of these is, the care staff, like the nurses and on to like caregivers and social services as well. There's a lot of pieces to the organizational structure that they are a part of. So hospice does take care of a lot of very varying things. So they have lots of ways to help somebody who is on hospice. So next slide, please. Hospice care is considered in almost every segment of healthcare. So young or old, it doesn't matter what part of life you're in. If you have a terminal illness, they are there for you and to support your family. Hospice services provide end-of-life care and can be considered a component of long-term care. It constitutes a community-based sector of the long-term care industry. Hospice care can be done in all 4 levels of long-term care. It can also be done in acute care hospitals. It can be considered home health care when the services are provided in the patient's home. Hospice General inpatient care provides short-term supportive care for individuals who are terminally ill and have a life expectancy of 6 months or less. In general, hospice care can be done in freestanding facilities, in nursing homes, or within hospitals. Next slide. Okay, this is the demographics. There are a lot of people who are served by hospice care. Travis, are you taking over this one?
I can.
Okay, you can if you want to.
Yep.
Okay, go for it.
No problem. So this slide talks a little bit about the history and how hospice was created. First line, total patients served. In 2014, an estimated 1.6 to 1.7 million patients received services from hospice. A number of jobs that make up the segment. The interesting part about serving all those people is this next bullet point. The U.S. hospice movement was founded by volunteers, and there is a continued commitment to volunteer service. In fact, hospice is unique in that it is the only provider whose Medicare conditions of participation requires volunteers to provide at least 5% of total patient care hours. The NHPCO estimates that in 2014, 430,000 hospice volunteers provided 19 million hours of service. In 2014, approximately 84% of hospice patients were 65 years of age or older, with 41% being 85 or older. Today, cancer diagnoses account for less than half of all hospice admissions, 36.6%. Currently, less than 25% of all U.S. deaths are now caused by cancer, with the majority of deaths due to other terminal diseases. Four of the top four non-cancer primary diagnoses for patients admitted to hospice in 2014 were dementia, heart disease, lung disease, and stroke or coma. 61,000 hospice programs exist today. The majority of hospices are independent, freestanding agencies, at 58% of those. Next slide.
This is Jake's, I think, and he's gone. So these were just some hospice organizations in Idaho, throughout different cities and towns through Idaho. You guys, I'm not going to read off all 19 of them, but I'll just read a few. Since we're close, Idaho Falls is close to Rexburg, I'll just name a couple of those. We have Aspen Hospice, Avalon Hospice, Hospice of Eastern Idaho, Solace Healthcare, just to name a few. Was this Jake's as well? I think. So he interviewed Sandy Herrera at Encompass Home Health, based out of Idaho Falls. She told me that the biggest challenge in balancing expenses versus revenue. She went on to say that as a hospice organization, they have the responsibility of taking what they get paid daily and then turning around and paying for multiple goods such as meds, DMEs, staffing, and daily supplies. She said that the biggest issue is always staying out of the red while giving the best care to all of their clients. Finally, she told me that as of January 1st, the government is restructuring the way that home health will be paid out. She told me that the government believes that areas that are more agriculturally based have lower income residents. Therefore, they are going to be reimbursed less money when it comes to paying for their care. This makes it difficult for a hospice organization to supply the demand to those rural communities. The opposite is true, however, for those that live in a more populated area. The government is willing to reimburse more for these residents. This being said, the people that live farther out have a smaller chance of getting the care that they need. Her job is to make all of the ends meet the means. And then our references. So that's our presentation.
Excellent. Very well done. It's a really, hospice is a really, it's a growing industry. I think culturally, I think a lot of it might have to do with culturally, at least in the United States, people are accepting a little bit more kind of the end of life concept of, not trying to have really robust and really aggressive treatments to eke out another month or 2 months, right? And some of those treatments can have really bad side effects. So a lot of people, I think just culturally, are starting to accept the fact that, look, I want to make these last months as good as possible. And so a lot of people are going the hospice route as opposed to aggressively seeking kind of a miracle cure. That's not true for everybody, of course, but in general. And so as an industry, it's really growing. So you guys did a great job. I wanted just to kind of highlight some key terms. One key term, palliative. I think you guys did a really nice job in explaining. I think, Janet, these may have been some of your slides. Explaining the difference between hospice and palliative, because hospice is more of a program, right? It's you accept the fact that you're within the last 6 months of life, you have a terminal illness, and you've kind of accepted the fact that you're not really going to seek kind of curative treatment, and so I'm going to enter this road, so to speak. Whereas palliative, you might not be terminal, right? You might not be dying, and you're trying to make somebody comfortable. So the term palliative, just outside of kind of terminal illness, think of palliative as trying to rid somebody of pain, or hiding the pain, or diminishing symptoms, or making patients as comfortable as possible, or relieving pain and suffering. So none of those words or phrases I've just said mean death, right? So palliative can be used in both the hospice setting, which is a setting of somebody accepting the terminal illness, but palliative also, as you guys described, can be used in scenarios where you're not in a hospice. You're just trying to help somebody feel better. Okay, not necessarily cure, but you're trying just to diminish symptoms. Now, when we use the term hospice and palliative care organizations, when that phrase is used that way, we do mean kind of end-of-life situations, because we've thrown in the phrase or the word hospice before the term palliative. But just kind of keep that in mind. You'll hear the term palliative thrown around in a hospital where somebody might not be terminal, but you are trying to provide palliative care. So just in healthcare in general, realize that term is associated with kind of helping relieve pain and suffering, diminish symptoms, making people comfortable. The other thing I wanted to point out is you shared some reimbursement data. I believe the slide that you shared was specific to Medicaid, which is one of the big payers, right? But did you, maybe in the reading or in some of your study, if we had to isolate and say who was the one largest payer of hospice and palliative care, who would we say?
Would we say private pay? Like I find that my work, it's more private pay than government pays, but I don't know.
Yeah, and I think, and I should probably make a caveat, right? I should have maybe.
Oh, sorry.
Because you're right. There are going to be some sectors of this industry that private pay is going to be the largest. So it may be very true for the area that you work in. Nationally, if we averaged everything out and if we tallied up all the dollars, Medicare is the single largest payer, and that kind of would make sense, right? Because a lot of people who are suffering, not all, but a lot of people who are suffering terminal illnesses are people who are older, right? And over 65, and almost everybody who's over 65 has Medicare. So just know that Medicare, if you had to isolate a single largest payer or payment source for this area of care, we'd say it was Medicare. The other thing I think you guys did a nice job in showing is that hospice is not, it can be done in many places, many sites of care, right? So most commonly, you're absolutely right. I think you highlighted the fact that it's mostly done at home, but it can be done in other settings, like a long-term care setting, a nursing home of some sort, but it can also be done in a residential area, and that's probably the most common. But just know that hospice can be done in many sites, and be aware of that. You also pointed out the eligibility, and for if we were specifically talking about Medicare, and you guys pointed this out, number one, you need a physician certification of some sort saying, you know, the normal course of this disease is that this patient will be will die within 6 months. 6 months or less to live is kind of a key metric to keep in mind when it comes to qualifying a patient for hospice. And this physician prescription is also required. Some people think that, you know, maybe patients and families are the ones who pay for most of this. Obviously, there are going to be some situations where that is the case, but overall, payment for this as an industry generally does not fall to the patient and family. They're going to have a portion to pay, but the bulk of this is usually paid by Medicare, as I mentioned before. And you know, hospice doesn't always. Sometimes people think that hospice means, oh, they're just going to give them narcotics, right? Well, not always. So narcotics and pain meds are not always the main treatment. They're frequently used when people are in pain, but that doesn't necessarily mean, just because you say, I wouldn't say that narcotics and pain relief is always a part of the care plan in hospice. It is frequent, but not always. And you guys pointed out that it's not just kind of the physical well-being in these last stages of life, it's also the mental and the psychological, right? And you even mentioned spiritual. So hospice is just trying to help that patient be the most comfortable that they can be those last few months of life. And I think all of us would be faced with spiritual questions and mental and psychological questions as we approach that major stage of leaving this life and going into the next, if we believe that. And so anyway, I just wanted to point that out, that it's also a major part of hospice care, is kind of that the holistic care. So really, really nice job. If somebody would please post the slides in the group chat for this week, and once this recording finishes processing, I'll post the link for the recording. Any last minute comments or questions?
Oh, I'll post the PowerPoint presentation on the group chat. Thank you, Brother Wolf.
Yeah, thanks. And if one other thing, if you'll just kind of monitor that. So sometimes your classmates will review your presentation. Most of them just say great job, and that's nice. But some of them might have questions, or they may make a statement that's not completely accurate. You know, because your group is kind of the expert in this area for our class. You know, you can respectfully correct people and point them to the right answers and right understanding. So monitor the site as well, and just make sure if people are asking questions, your group is kind of addressing those.
Okay.
Okay. Thanks so much. Have a great night, everybody.
Thank you.
Thank you.
Bye bye.
Good night.
Bye.